Welcome back, everyone. We're going to continue with our Critical Care Symposium with yet another controversy in resuscitation and critical care, and that is the use of bicarbonate in sick or critically ill patients. It is very much a controversy as to when and if we should be giving this medication. And to take us through this discussion is Dr. Caleb Chan. As many of you know, Caleb is a graduate of our EM/IM Critical Care program. He is currently an assistant professor in the Department of Emergency Medicine, along with the Division of Pulmonary Critical Care. He's the assistant medical director of our medical ICU here at the University of Maryland Medical Center. He's also the associate program director of our Critical Care Medicine Fellowship. So without further ado, Dr. Chan, educate us on bicarbonate use.
Thanks so much, Dr. Winters. I got to put my MD on there. I promised I graduated medical school. And I just realized that. And I just apologize. I've been a little bit under the weather for the last week and a half. And so a major shout out to my wife who was taking care of me on Mother's Day and bringing me food while I was in bed. So I apologize for all the coughing that may happen. I promise it's not COVID, at least it wasn't when I checked a while ago. So again, bicarb, I'll kind of dive into a little bit. I have no disclosures, despite my wishes. Objectives, again, we're just going to be talking about bicarb, talking a little bit about metabolic acidosis and what that is, and some misconceptions, and when do we actually use it. So just to dive in a little bit, right? So say you just walk into your shift, right? You just got sign out maybe. A nurse runs up to you and says, "Hey, doctor, I have this stat lab that came back. This is the pH." Just take a moment and just think about, all right, what are the things that you're thinking about, right? What's running through your mind? What are the things that you're going to be asking for, maybe medication-wise? What are you looking for in the patient? Just take a moment and just think about it, and we'll kind of keep going. So we'll just think about maybe a little more clinical context. So say you turn around and that stat lab that came from is this patient who's getting wheeled down the ambulate. Hopefully they're actually getting bagged and not just have a non-rebreather on. But again, right, we do chest compressions first, I guess. Just what I found on Google. So so does this change what you're thinking about, what you might be doing, what you might be asking for out of that code cart? Think about it. Say this is one of the patients that you got sign-on on. Unfortunate boarding issues in our hospitals and emergency department. This patient, came in with a cellulitis. Now they're on multiple pressors. The levo's at 0.8 mics per kilo per minute. They're on vaso. They got a rational approach to their fluids already, and despite that, they're still on multiple pressors. Their intern nailed that A line, but that's what it's showing, and that's the pH of 6.9. Right? What are you thinking about? Like, what might you be asking for? Dr. Butler just gave a great talk. We just kind of touched base a little bit too about what would we do. But say it's a patient that you're about to intubate. Say it's a patient that, again, this darn boarding patient that was sitting on BiPAP all night. The MICU fellow came down and said, "No, this patient's not appropriate. Send him to the IMC." But they had a worsening pH. Their CO2 is up. They're not tolerating their BiPAP. The nurse comes up and says, "This is the stat." She's just waving in your face, right? This is 6.9. What would you do? Right? Does this change what you're thinking about and what you might do? And then, I think this is probably a little bit more familiar to all of us, right? So say it's a patient that came in from home, polyuria, polydipsia, history of diabetes, said the kilometer's not reading, it's not showing me numbers, it just says HI, right? And then the stat labs come back and pH is 6.9. Right? What are you thinking about? Does this make a difference? Does this make a difference for what you're going to do? And then finally, so again, maybe this is that boarding patient, that cellulitis patient, your colleague put in a Foley overnight. That's all it's put out since, for 12 hours or so. And that's the pH, 6.9. Again, does this change what you're thinking about? Does it change what you're going to do? So again, all disclosures, I'm not a chemist at all. I have to say chemistry was my least favorite subject in all of high school and probably college as well. I hated acid-base and chemical reactions and stuff, and I was going to put a picture of one of my midterm exams on there, but decided it was a little bit too embarrassing to show how poor I did on that one particular test. But again, we're not going to dive into the nitty-gritty of acid-base stuff, right? At the end of the day, this is not a chemistry lecture. I'm pretty sure most of you would be half asleep if I kept talking about PKAs and all that, and I probably would be too. If you want, Dr. Spiegel is much more an expert and will dive into a lot more of the acid-based stuff than I will. And today we're going to talk about it, we're going to touch on some of the stuff, but I'm really not going to dive too far into it because I think at the end of the day, what you guys really care about is really clinically what does this look like. We're going to talk about maybe where some of the basics might apply and why it might affect, why it might or may not work, but we're really not going to talk about it too much. Right, so metabolic acids, I think we all remember from medical school for the most part, right? Your pH is lower than the physiologic normal, so below 7.35. It's not due to your CO2, it's associated with the lower bicarb. But I think what we really care about is these patients that are sicker, right? Just because you get a pH of 7.34, 7.32, you're like, oh, it's probably within the realm of lab error. I don't really care about that all that much. But these patients that are sick, right, this pH is less than 7.2, bicarb less than equal to 20, right, that have an elevated lactate or elevated SOFA score. These are the patients that we're really thinking about. And so when we talk about some of these studies, these are the patients that, the patient population that they're usually focused on. And again, these are the ones that I think are a little more clinically relevant. Just want to start off a little bit just about kind of basics, right? I think we all learn in our biostats class or every journal club that we've been in, right? Correlation does not imply causation. Right? That just because there's two outcomes that happen, we see them, it doesn't necessarily mean that there's a transitive property, right? That one causes the other, but let's just think about it for a second, right? When we think about septic shock, say that patient with that cellulitis, you get their pH, they're acidemic, and as they're bleeding, right, their pH is getting worse, their pressures are rising, and despite all of that, right, they're worsening pH, they have a poor outcome, right? Or this is the patient that went to the ICU and you checked on your patients after you chart checked and you saw that worsening acidemia and their ultimate code, right? I think for many of us, we're like, oh, that the patient just, that acidemia just couldn't really correct it. But just take a step back and think, right? So is that really correlation, right? Does that septic shock, did it just also happen to cause the acidemia and it also happened to link to the poor outcome? Because I think if we change that transitive property thinking in our mind, that causation, we disrupt that a little bit, maybe we rethink how we approach acidosis and why or why not, why we may, how we approach it and what we might do. Right, so just to drill at home a little bit more, right? So say there was this study out in Denmark. They had 6 rowers. They were like Olympic champions or national champions, world champions, and they rowed for 2,000 meters, and they took their blood right after, right? And they checked their pH and their labs after, and so they found their pH was as low as 6.74, right? Bicarb was undetectable, and their lactate was 32. Right? When's the last time you saw a patient with that, right? How did you think that patient was going to do? I loved one of my favorite parts of the paper. The authors wrote that all the study subjects were conscious, which is probably more than I could say for myself if I had to do that. But I think that's important, right? That the patients are acidemic. Their pH is low, their lactate is up, but they're not getting chest compressions. Also, this is a shout out to Cornell. It's their Cornell team. But and just to kind of drill it home a little bit more, right? These patients that you guys may see, right, on a day-to-day basis, right? Your seizure patients, where you get labs, stat labs as they're actively seizing, right? You guys have all seen it. Their pH is low, their lactate may be up, but guess what? You get them their versed ed, you capital load them, they wake up from their seizures, and some of them may go home later that day, right? The acidosis, the acidemia, doesn't necessarily lead to a poor outcome. Like we talked about before, maybe our DKA patients, right? You guys have all seen DKA patients who get better as we treat their acidosis with their insulin drip and with fluid, but they tolerate their acidosis and their acidemia well, right? They don't tend to just have a cardiovascular collapse in front of you, although that may happen, but that's, talk about the hyperkalemia and other factors. But they tend to still tolerate that pH of 6.98 before you, right? Sometimes they're awake and talking. And then finally, more relevant for kind of our critical care players with ARDS, right? We intubate them, and this isn't necessarily a metabolic acidosis, but as we put them on lung protective ventilation strategies with the low tidal volume, their CO2 goes up and their pH goes down, but they tolerate it well. They can tolerate pH. We allow for permissive hypercapnia for a pH of down to 7.2 and sometimes even further below, and we don't see any hemodynamic changes. So I think this is just to point out again, right, that correlation, right, that we see with acidemia and poor outcomes may not necessarily be a causative property, right? That we see some, and the patients can tolerate acidosis, or acidemia can be different in different patients. So, here's the star of the show today. This is bicarbonate, which we'll be talking about. I just pulled this picture off Google. I do not endorse all the things that this thing is endorsing. I didn't know that it treats mouth infections or canker sores, and I'm not sure where the enhances athletic performance comes from, but I just thought that there was a good picture, and we have our molecule up there. Again, I'm not going to dive into the molecule too much and the nomenclature and all that stuff, but here we see an associated sodium, right? Most of the time there's a cation that's associated with bicarbonate. Most of the time it's sodium bicarb, right? When you're reaching your code card, it's the sodium bicarb amp that you're going to be reaching for. All right, so let's just talk about a little more clinically again, right? So going back to this patient, this hypotension patient, septic shock, maybe they have an elevated lactate as well. What does the data really show? And so I put this picture up because unfortunately, I apologize to all you animal lovers and dog lovers that most of the studies that are done with metabolic acidosis and bicarb, a lot of it is done in animals, right? So there's dog studies or pig studies or rat studies, and it's really the studies are not human studies. There's some retrospective trials, there's some observational ones, but again, things that don't really that don't have high level of quality. And so I think it's just really important as you see some of the guidelines that come out, as you guys think about why we should or shouldn't, that the data behind some of the things that we do may not necessarily be great. So we can see that these induced acidosis in these dogs, maybe they don't tolerate it well, but you'll see as you look at the literature that when actually in humans, in vivo, it may not necessarily be true. And so again, there's a wide body of literature. A lot of it is these animal studies, whether sometimes they take like tissue samples out of the body and then put it in like an acidotic solution and look how it functions there. There aren't a lot of randomized controlled human studies. And so I'm going to focus on the ones that I think are particularly relevant. There's, again, a lot, but the ones that I'll mention are the ones that are really, I think, are a little higher quality. And so one of them that I'm going to talk about here is this one where they took these patients that were in the ICU, they were on multiple pressors, and they had PA catheters, right? So they had PA catheters in there so they can monitor their hemodynamics. They could see what their stroke volume was, they could see what their cardiac output, their index was, right? And this is kind of the best test that you could have, right? If you're thinking, hey, I have a hypotensive patient who's in shock and they're acidotic, and I can give bicarb to help their hemodynamics, right? This is probably the best way they're going to be able to tell. Unfortunately, with this study, so I had 14 patients, again, smaller, but when they gave bicarb, so they randomized to either bicarb or normal saline and measured those hemodynamics after, there was no significant difference between the two in terms of, even despite a correction of their pH, there was no difference in hemodynamics. So there was a transient increase in cardiac output, but there was no difference between the saline bolus and the saline infusion and the bicarb infusion. And so what you could derive from that is that it's not the correction of the alkalosis that may help with in this patient that received bicarb, but it's actually just the volume load. So whether there's this preload augmentation that has happened rather than actually the correction of the acidosis. And so, I think the question is maybe a little bit of why, right? I think a lot of times when we do stuff in medicine, we think that, there's a solid physiologic reason for, this makes sense, right? It makes sense for why, if I do this outcome should happen. And so I promise not to do too much into the chemistry, and I promise it doesn't get too much more than this. But there's, within our bodies, there's a bicarbonate buffer system. Right? So there's an equilibrium between these molecules, and the pH is going to end up being a result of the ratio between some of these molecules. And so we have bicarb all the way over here on that right side. But the thing is, when you administer bicarb, right, you're going to increase that concentration of bicarb, and you're going to cause the equilibrium to start going towards that left side, right, to form carbonic acid there, and then through carbonic anhydrase, produce CO2. And the other thing to realize is that our bodies, I think, despite what we think, is that there's multiple compartments. So even if we correct numbers in one compartment, say our intravascular system, when we push bicarb, it actually may not affect a different compartment. Specifically, we're talking about intracellularly. And so in the body, bicarb actually doesn't diffuse just straight from the vascular system into cells very well, but carbon dioxide does. And so what might happen if you give someone bicarb, right? So they're intravascular, in their intravascular system, their bicarb goes up, you produce more CO2 because of it, and that CO2 diffuses into the cells before the bicarb does. And so now in the cell, now you have a higher concentration of the CO2, and in the cell, and then you start shifting the equation the other way, right? You start producing carbonic acid, and subsequently you produce hydrogen ions. And so you can actually cause intracellular acidosis, even though the blood pH might be higher. And so I think that's why it's really important to take some of our physiology a step further and say that even though we're correcting this number, that actually what we physiologically want to happen, right, to help with pressure requirement or whatever, may not actually be the case. All right, so how about we take it to the next level, right? So again, you guys have all been in codes probably in the last shift or last week, right? What about in these patients, right? When we get that code card, it's in there, right? That bicarb push is in there. And I think we're very tempted, right? I think in the day when those patients come in, we're gonna throw this very, very beautiful kitchen sink. I looked at a bunch of them. There's Kohl's and Sears. I thought this was supposed to be pretty, but if you like the farmhouse style, I guess. But I think it's tempting, right? And I think it's understandable. We're saying, hey, this patient's already dead. How am I going to really hurt this patient more? But let's just take a second to think a little bit more. And we're not going to talk about, at least here, we'll talk about later, but overdoses or hyper-K, but just kind of general cardiac arrest, right? And again, I understand the sentiment, but I think the problem is, right, sometimes when we start going through our algorithms and we're reading these codes, it starts to look like this, right? Oh, you just give a little bicarb. All right, the stat lab came, we shocked them, but the patient's a little, maybe we'll get a little by bicarb. And then the nurse, do you want another bicarb push? Like, okay, yeah, let's give him more bicarb. I think the CO2, the pH is still a little bit low, so let's give him more bicarb, right? So I feel like sometimes, right, we kind of keep going, right? And unfortunately, and I'll confess, right, I've been there, right? I've been there in those patients where that number, that 6.9 is low, and it's tempting to think, hey, if I fix this, I'm going to fix this patient, right? They're going to come back from the dead. But what does the data really show? And unfortunately, again, there isn't great data, right? There's not a lot of randomized control style studies out there. There's a lot of retrospective studies where they look at associations or prospective studies. And there's one where I was like, oh, bicarb leads to better ROS scan outcomes. But if you look at it, it's just an association. There was no randomized controlled trial. It was just an association. And I think you guys are all smart enough now to realize that correlation does not imply causation, right? And so what about these studies were humans, And so there was a smaller pilot study recently in 2018. They had 50 patients that they randomized to bicarb or to just normal saline pushes. It was blinded. And they found that there was no difference in ROSC or neurologic outcomes. And so that's probably the most solid in terms of human studies. And I think taking it into account with the overall body of literature, there really is no studies that show benefit. And I think the other things to think about is that there can be harm, right? I think bicarb, unfortunately, is not a benign drug, right? And most of the drugs, or all the drugs that we give, there's some adverse outcomes, and so or effects. And so with bicarb, something to think about is hypocalcemia, right? So if you give bicarb, if you raise pH, you actually kick off hydrogen ions off of our albumin and our proteins, and those bind calcium, and you actually decreased ionized calcium in these patients. Again, calcium in cardiac arrest is probably a whole nother talk for another time. But if we think about it, right, a lot of times we think about calcium and hemodynamics, and again, that you could actually impair the recovery of some of these patients. Oxygen delivery, going back to med school a little bit, but if you remember your oxidation dissociation curve, your hemoglobin dissociation curve, one of the things that shifts it is pH, right? So if you are increasing the pH of a patient, you're actually changing the hemoglobin conformation to have higher affinity for oxygen. And so in these patients where you're trying to improve oxygen delivery, right, that's the whole point of trying to increase MAP or trying to bring them back, you actually are causing them to have impaired oxygen delivery to the tissues, which is what you really care about. And so they tested this in human subjects where they gave acetazolamide to give them a metabolic acidosis and gave them bicarb back. And they actually found that there was that impaired oxygen delivery that lasted for 8 hours. Again, not great signs of benefit and potential harm. So not only that, sodium bicarb is a very, very hyperosmolar solution. It's 50 milliequivalents of sodium bicarb in 50 milliliters. And so right, if you give 3 pushes, it's 150. If you've given more than 3, right, now we're starting to get hypernatremic. What if this patient had coded from a CHF exacerbation, right? And now you're loading them with sodium bicarb. Right? Is that really going to help you get ROSC on this patient? Or just take a moment to think, right? As emergency medicine providers, right, as physicians, you have to think about not just what you're doing, but to think about kind of the why, right? That you guys are not just algorithm followers, right? But that you guys have some critical level of thinking beyond, what the algorithm says. All right, so Dr. Butler gave a great talk on RSI and critically ill patients. And so, let's take a moment. What about this patient that you intubate, right? Remember that nurse was waving that 6.9 in your face, right? How many of you are tempted to be pushing bicarb, right, before you intubate this patient? Or it's a patient that you already intubated, they're on the ventilator for that bad COPD exacerbation, or maybe you have to intubate them. They had a metabolic acidosis, and for whatever reason, and I think that's dangerous in and of itself, but you had to intubate them, right? And they have a metabolic acidosis and their pH is 0.9, right? Should we be pushing bicarb before we intubate them, right? And I want to bring it back to this equation a little bit because part of the thing, what controls this is the lung here all the way on the left, right? So if you give bicarb, you're going to be producing CO2. So in 1 amp of bicarb, you actually will produce a liter of CO2. So for most patients, most people, we produce about 200 milliliters of CO2 per minute. But if you push an amp, you're giving a liter of CO2. And so at worst, right, in a patient who already has been maxed on their minute ventilation, right, that or either have a bad COPD exacerbation, so they're not able to clear their CO2 in the first place, or they're your acidemic patient who's been breathing at 40, at 40 liters per minute, and they're already maxed and you're pushing bicarb, right, you're not really going to be able to blow off that CO2. So at worst, you're not going to have any difference in your pH, and at worst, right, you actually increase the level of CO2 in this patient. So this is not something that really has any theoretical or any real data behind it either. What about DK? So I think for the most part, I think for all of us, we have moved away from repleting bicarb in these DKA patients up front, and that's based off of some smaller randomized controlled studies that were done decades ago at this point. And so, but I think it can be tempting, right? So the studies, unfortunately, do show that there's no significant difference, that there's no benefit to giving bicarb in these patients. But the guidelines still say, so from guidelines of what pH of less than 6.9 and some hemodynamic changes, if they're on pressors, that you should consider giving bicarb. But the studies also showed that there was some association potentially with cerebral edema, especially as we think about our pediatric patients. Again, the level of quality of data is not great. It's, you could say, hey, this patient, was sicker, and so that's why they got bicarb, and that's also why they happen to get cerebral edema. Their DKA was just worse. But there's also potential for worsened ketosis in some of these studies that they found as well. So again, bicarb, not really any data in DKA as well. So you could say, hey, Dr. Chan, you've kind of talked about all the things that I should not be giving bicarb in, or there's no data behind any of what we're doing sometimes. Well, there are some studies and there are some situations where it is useful. So the one kind of major study that you'll hear a lot of our critical care providers talk about is this bicarb ICU trial. So specifically in these patients with severe metabolic acidosis that we're talking about, the ones that are sicker, right, that pH of less than 7.2, they have a lactate, their SOFA scores are up, and they randomize these patients to, so almost like 400 to bicarb or no bicarb. and their primary outcome was mortality at 28 days and more than one end organ failure. And they found that there was no significant difference. But in a predetermined subgroup, and I think, again, hopefully that maybe raised a little bit of a red flag, but in this predetermined subgroup of patients with AKI, they actually found that there was a benefit to these patients. They actually found decreased mortality and decreased rates of need for renal replacement in these patients. And so, again, weak level of evidence for, but this is probably the major one that we cite for use of bicarb, specifically with these patients with AKI 2s or 3s. And I think one thing also to realize is that in this study, there was actually a lot of crossover. So the patients that were randomized to not to bicarb, to not receive bicarb, actually ended up receiving bicarb. And so maybe there actually was a lack of treatment effect because of that crossover. And then I think this is one that we talked about before, but again, this is probably one of the more solid indications for bicarb, right? So our overdose patients. So specifically, we talk about TCA, not TSA. So TCA, right? I think I think we're all pretty familiar. The alkalinization, may help, but it could also just be, again, as we said before, it's a high osmotic load. This high sodium content competes with that TCA to overcome the sodium channel blockade from your TCA overdoses. And then salicylate. So, in salicylate poisoning, there's different molecules. So there's an unpolarized one on the left and the polarized one on the right. And as you alkalize, it shifts towards this polarized version. And so the reason why is that what this matters is that the unpolarized molecules can actually cross the blood-brain barrier. And so that neurotoxicity that we worry about, theoretically there could be some benefit as we shift these molecules to the unpolarized form to prevent crossing over and to increase renal excretion. All right, and just to follow up, or just to finish up, this is our last kind of indication. I know here at Maryland, I could put up any EKG that's abnormal and it should be hyper K, right? But hopefully this one stands out to you guys. But I do want to just emphasize for hyper K in particular, that if you amp a bicarb, so if you push an amp of bicarb, it actually won't really significantly change the potassium. So the reason why is that there's a solute drag effect. So if you give such high osmotic load, that actually pulls water and potassium out of these cells. And so any alkalinization effect, I guess that you would help with the hyper K, actually gets negated by the pulling of the potassium out. So if you're going to give it in an isotonic solution. That's when you give your 3 amps of bicarb in D5W and run it over some period of time to prevent that solute drag effect. All right, so again, so just take some take-home points. Hopefully I convinced you guys, or at least showed you some of the data that shows, hey, there's really not great data for most of the times when we're trying to use our bicarb. So maybe try not to empty out your code carts too much, right? Cause our bicarb shortages that we have in the hospital. And that not only that doesn't really change patient outcomes, but there's some potential harm. That acidosis in itself, right, may not necessarily be harmful, but at the end of the day, we need to treat the underlying cause, not necessarily fix the acidosis in itself. And then, again, feel free to continue to use bicarb in our clear indications, whether it's our TCA overdoses, salicylate, hyper K, or those with AKI. Thanks.
Dr. Miller, question for Dr. Chan.
Not awake quite yet. All right, Dr. Chan, thank you so much. We have one question from Mahmood, who asks if you would consider giving bicarb in DKA for a significantly low pH and a patient in cardiac arrest.
So, I mean, I think the data overall, I think, again, right, is the question about what the cause is, right? So I think most of the major cause of mortality in DKA and these arrests is hyper K. And so probably bicarb, we just talked about before, bicarb is not really going to change that acutely. If you're just pushing amps, you're not going to be running a liter of isotonic fluid as you're trying to resuscitate this patient. And so I probably would lean more towards your calcium and your other hyper K adjuncts rather than bicarb.
Very good. That's the only question right now. Thank you. much.